if we can identify high or low risk endometrial cancer before surgery. Thank you.
I think I need advice to change the slides. Okay. Can you show me?
Donkey.
Okay.
Donkey.
So the first one. Here. Oh. Okay, now I'm okay with the techniques. Dear colleagues, this is my 4th time in Egypt, and I must say that I have enjoyed every time, and I wish to thank the organizing committee for inviting me here also this time. I bring you greetings from Finland, a country known for its thousands and thousands of lakes, and also for its snow, but snow you will see at the end of my presentation. I also bring you greetings from FIGO, the World Organization of Obstetrics and Gynecology. Egypt is one of the 130 member countries, and Egypt has done a great contribution to FIGO activities because 2 of the former presidents of FIGO have come from Egypt. And I wish the gynaecologist and all of you, of course, to visit the FIGO website because there is a lot of good information available there. And especially I encourage you to download the FIGO app on gynecological cancer management. There you can find the staging and also good advice for treatment of different gynecological cancers. And I also invite you to participate the regional congress in Dubai now in April, and then the global congress in Rio in October. But if we then start to discuss about the difficult question, can you identify low and high risk endometrial cancers preoperatively? So there are more than 300,000 cases per year globally, and I heard that in Egypt the number of ovarian cancer and endometrial cancer is about the same. Globally, I think that, or in developed countries, the endometrial cancer is number 1 of gynecological tumors. Luckily, these tumors are, in most of the cases, early stage and have a very good prognosis. The risk evaluation usually is based on stage and histology, and it is no surprise that if you're using those, there is a lot of intra-observer variation and inter-observer variation, and that means that the same patient can be treated differently in different institutions and also in the same institution at different time points. So there is a need for improvement in classification of high and low risk tumors. Of course, imaging is a very important tool when you do preoperative evaluation of any cancer. And here on the right side, you can see a scene from the FIGO app advising you on investigation of endometrial cancer. Here's a picture of a PET MRI indicating very small lesions. So in some cases, it is a really valuable tool in imaging. So why is preoperative evaluation so important? Of course, we need to decide about the extent of the surgery, we need to decide whether there is a need to centralize the treatment, and we all wish to avoid undertreatment and overtreatment. And the basic question is where and by whom the patient will be operated and treated. Because, of course, in low-risk cases, sometimes only hysterectomy or salpingo-oophorectomy is a proper treatment, and then in high-risk cases, you need more advanced surgery and also adjuvant therapy. If you undertreat the patient, there is an increased risk of recurrence, and if you overtreat the patient, there is an increased risk for side effects of surgery and radiotherapy, lymphedema, and effects to bladder, rectum, and vaginal mucosa. This is the most simple classification of endometrial cancer, and it indicates that only 5%, roughly 5%, belong to the really high-risk group. For years, we have been using this Pochmann subtype classification, type 1 and type 2, type 1 being hormone-dependent, endometrioid type, good prognosis, and type 2 being non-hormone dependent, non-endometrioid type, and worse prognosis. But we all know that there is a lot of discrepancy between these two, and also a lot of overlapping and heterogeneity. So this classification is not enough. ESMO, ESCO, and ESTRO gave out 2013 a new classification, and they had a consensus meeting 2014 and came out with this 6 grading classification that takes into account myometrial invasion, lymphovascular space invasion, and also histotype. And this classification is currently considered to be one of the best in clinical use. Then came data from the Cancer Genome Atlas. And here you see that there are many classifications, and that indicates the difficulty. So this Atlas genome data gave 4 different subgroups. Pole mutation group being the smallest one and having the best survival, and then P53 abnormality group having the worst prognosis. So in Canada, at the University of British Columbia, there's a group who then made a molecular classification called PROMIS and tried to use this genome data to classify the tumors better. So they created a diagnostic tree where they used both immunohistochemistry and sequencing. So this is based on absence or presence of particular proteins and absence or presence of some mutations. And they wanted to see if this classification can be used preoperatively. So they had samples from 60 patients. They had preoperative sample biopsy and then also the hysterectomy sample. And they compared those two. They compared grade, histology, and this molecular subtype, and they had 3 skillful pathologists to do the evaluation and trying to figure out what is the concordance of these 3. And it is no surprise, as said, that grade and histotype are very subjective things, and the reproducibility is not optimal between these two. It was not optimal between the biopsy and hysterectomy sample, and also not between the observers. Kappa values were lousy. In contrast, by this molecular classification, the kappa values were good, and the concordance between the biopsy and the hysterectomy sample was good, and it was good also between the observers. So the results were more reliable. And they were, the best concordance was seen for B53 abnormal cases. So from this small study, their conclusion was that this molecular classification can be used in preoperative samples. And they predict the molecular features in the hysterectomy specimen very well. The concordance is superior to grade and histological type, and this has a potential to become a diagnostic tool for preoperative cases. Then they continued to confirm this data in larger material for more than 300 patients, and they compared this molecular classification to ESMO classification. What they showed was that in ESMO classification, low and intermediate group were almost the same, whereas in this molecular classification, there were 4 groups, so the intermediate group came out better. So there was an improved discrimination. And this holds true also for overall survival, disease-specific survival, and progression-free survival. So from this larger study, their conclusion was that molecular classification can be achieved using clinically applicable methods. It gives independent prognostic information, and it gives consistent, reliable, biologically relevant categorization for these tumors, and it may guide treatment. So to answer the question, is preoperative identification of low and high-risk tumors possible? So I think that at the moment you can say yes for clinical trials currently and in future for clinical use when these tools are more widely available. Of course, there are still some challenges. The technology is difficult and it is not available in all institutions. And we don't know yet how these 4 different categories should be treated. So therefore, early diagnosis of endometrial cancer is still important. Thank you for your attention.
Thanks a lot, Dr. Grénman, for this nice lecture. And now come back to breast cancer.